and gentlemen, welcome to Clinical Journal Club, 19th of December, 2018. The image in the New England Journal this week concerns an 18-year-old man who presented to the emergency department with chest pain, 18 years old. And this is a coronary angiogram. And the one on the left, we can see the right coronary artery and the left anterior descending coronary artery. And we see striking aneurysmal dilatations in the proximal coronary arteries. So we have to know what causes aneurysms of coronary arteries. And in the image on the right, we can see that the left anterior descending is now closed because these abnormal dilatations result in eddy currents that interferes with endothelial function and makes vessels prone to thrombosis. We're offered 5 differential diagnoses. I don't think this is Hodgkin's lymphoma. Familial hypercholesterolemia might cause atherosclerosis in an 18-year-old if it's an homozygous, if both alleles are affected with LDL receptor malfunctions, but arteriosclerosis doesn't look like this. A Marfan syndrome involves the ascending aorta, and we'll talk more about that later. This is not Marfan syndrome, and this is certainly not rheumatic heart disease. This is Kawasaki's disease. And Kawasaki's disease is an acute idiopathic self-limiting inflammation of medium-sized blood vessels, and the coronaries are commonly afflicted. And the disease involves children that have an acute illness during early childhood and show up 15 years later with these aneurysmal dilatations and coronary artery disease. This youngster was diagnosed during an acute episode of Kawasaki's disease, which is also not that easy to diagnose. And he was even treated with immune globulins that are currently the proposed treatment and developed these aneurysmal dilatations anyway. If we look at this syndrome, we see that it's more common in Oriental countries than in Europe or North America. During the acute episode that is presumably of viral origin, although even that has not been proved for certain, we see that the children develop conjunctivitis. This is a strawberry tongue in panel B, which is also seen in youngsters with scarlet fever. We see an anogenital rash. We see commonly erythema of the hands and feet. And in panel G, this is a site where a young child had been vaccinated with BCG against tuberculosis, and the site of this vaccination becomes remarkably erythematous for reasons that are not clear. And this is in panel H, there's a perianal erythematous rash here. There are no cardiac findings during the acute episode, but as we see here, as these youngsters advance in age, this is an example of aneurysms of the coronary arteries that are calcified. This is not an angiogram. This is a plain röntgenogram of the chest showing calcified coronary artery aneurysms. Remarkable. So this is a snapshot diagnosis, Blickdiagnose, as we would say in German. The first topic concerns the influenza epidemic of 1918. 1918 was 100 years ago, end of the First World War, and before the war was ended, began a remarkable epidemic of upper respiratory and lower respiratory disease that was termed influenza. This actually began in the United States and presumably was brought to Europe through transport of young soldiers that were infected. It spread through Europe like a wildfire. And if we look at this diagram from the Times, we can see London, Paris, Berlin, New York, and you can look at October 1918 through beginning of December, a huge epidemic of this condition in all of these European cities, and entire dormitories or gymnasia were filled with cots of these poor patients with influenza. And this influenzaal disease was secondarily infected by pneumococci, Haemophilus, staphylococci, etc. And the mortality rate was remarkable, so that 50 million people died in Europe and the Middle East and in North America, Canada, the United States of influenza, and commonly relatively young patients. Old patients, people my age, were relatively immune because an influenza epidemic had moved through Europe in the 1890s, and they had antibodies against some influenza viruses. And we now know that this was the strain that we called H1N1. Hemagglutinin and neuraminidase are surface proteins that are expressed by these viruses, and these mutate at a relatively high rate, and they're numbered. And this strain is H1N1. It's still around, and in the last 20 years or so, bodies have been exhumed, young people that died of influenza, and this virus has been isolated from these bodies. And in this brief report to commemorate that, in the New England Journal, we can learn about this. What isn't stressed here is that this epidemic moved on further eastward, and at least 50 million people also died in India and China. It moved all around the world. And in this short picture in the New England Journal, we see the deathbed photograph of Egon Schiele, who was an artist of this time, a modern artist, as you can see by this insert of a drawing that he made that I placed here. And Schiele died at age 28. His young wife, who was 6 months pregnant, died also. Common of the times. Is it possible that such an epidemic could recur? That's true, and that's why we're continually worried about influenza virus epidemics. Have you all been vaccinated, would be my question, against the current strains that are moving around Europe. The first topic in the New England Journal concerns mitral valve repair via a transeptal puncture and the placement of a mitral clip that results in a bicuspid mitral valve. Mitral valve disease, when I was a medical student, was generally caused by rheumatic heart disease, where the valve was primarily affected. But now, most cases of mitral insufficiency involve dilatation of the mitral valve ring that occurs after myocardial infarction or cardiomyopathy or what have you, so that the mitral valve ring dilates and the cusps of the mitral valve can no longer close. To deal with that, this clip is placed, which causes a relative mitral stenosis, but it moves the apertures close enough together so that the degree of mitral insufficiency is decreased. Now we have to keep in mind that the primary treatment for this kind of mitral insufficiency is to treat the heart failure. And if the heart failure is better and the heart is no longer so dilated, then the chances that the mitral cusps will close or come close to closure, of course, is increased. And we look at two trials. The first trial was performed in France, where patients were randomized to mitral valve clipping or placebo, or no intervention, treatment for heart failure alone, and the primary outcome in this trial was the composite of death or unplanned hospitalization for heart failure at 12 months. I'm not going to show you the patients in this trial yet, for reasons that will become obvious in a moment. But if we look at the adverse events that occurred in the patients that got the clip compared to the patients that didn't, adverse events related to clipping occurred in the clipped patients, but they were relatively uncommon. There were problems with device implantation failure or bleeding for some reason. This is a transeptal puncture, so this is not a trivial intervention. This trial was sponsored by the French Ministry of Health. The valves were donated free of charge by Abbott, that's the company that makes these mitral valve clips. And what we see here is that at 12 months, there was absolutely no difference between the control group and the intervention group in any primary or secondary event. No difference in death from any cause, no difference in cardiovascular deaths, no difference in unplanned hospitalizations, and no difference in major adverse events. Now, the authors of this trial admit to some limitations. In some patients, the procedure couldn't be performed properly. I would also draw attention to the fact that only one clip was placed on the mitral valve in any given patient, but the follow-up was fairly good, and the power of the study, if there's a difference between these two therapies, basically should have become obvious. But in this trial, there was no difference. Now we move to the next paper. Same study, different name. This study was performed primarily in the United States. This study is called the COAPT trial. And again, patients with severe heart failure, not due to primary mitral valve disease, but due to dilatation of the mitral valve ring, were randomized to clipping or to placebo. The endpoint, the primary endpoint, was the same. The follow-up in this study was 24 months, although we look at the data from 12 months. And this trial was sponsored by Abbott that produces this mitral valve clip. And if we look here at the primary endpoint, suddenly everything is statistically significant in the primary endpoint and in all the secondary endpoints. The primary endpoint was reduced by half in the intervention group. The degree of mitral regurgitation was reduced, although that happened in both studies. Deaths from hospitalization or heart failure was reduced. A bunch of variables that are all listed on this table were better in the device group compared to the control group. And the differences are dramatic. And we see that the differences are already markedly statistically significant at 12 months, although we have data here for 24 months in this trial. Freedom from device-related complications is almost 100%. Basically, there were none. Death from any cause at all is also better and reduced in the device group compared to the control group. And we can look at these data expressed in this table, and all of the items here are statistically significant, and the reasons that the adverse events are better in the device group compared to the control group is because of adverse events that occurred in the control group putatively related to heart failure. What's responsible for this? If we look at this forest plot from the COAPT study, we see that the advantages were already accrued in patients with fairly mild heart failure. New York Heart Association classification 1 to 2, 3 to 4. advantages were seen in all these patients. And in basically all the subgroups, irrespective of age and gender and cause for mitral insufficiency, etc., all these things were better in the device group compared to the control group. Now we'll compare the patients in the COAPT study to the MITR-FR study. And age is similar. These are people early 70s. The distribution of gender is also not remarkable, whether they had ischemic cardiomyopathy or prior cardiovascular revascularization. I think these things are fairly similar. If we look at New York Heart Association classifications, we get the impression maybe the patients in the COAPT study were a little sicker, although I think if I look at these 3 to 4 classifications here, 50%, 63% here, and here it's 50%, 54%. I don't think that's that different. If we look at pro-BNP values in the French study, they're about 3,500. And if we look at the pro-BNP values in the COAPT study, they're about 5,000. So they're higher, not the same labs. These assays are variable. I don't know what that means, but it's possible that the people in the COAPT study had mitral insufficiency that was more pronounced than the people in the French trial. And we would think that the people with worse mitral insufficiency might benefit more than the people with less severe mitral insufficiency, although the New York Heart Association classification scores, I didn't think were that different. But we have an expert that then discusses these two trials, and he raises various possibilities that the medical management might have been different in the two trials, although medical management in Europe is no different than the United States. Possibly there was some difference in baseline valvular and ventricular characteristics. I didn't look at all the information in the supplements, but I'll leave that up to you, maybe. That maybe the fact that the people in the MITR-FR trial only got a single clip and some of the people in the COAPT trial got 2 clips. I don't know, possibly. But these are the things that are discussed. It would never occur to me that sponsorship might play a role here. The MITR-FR study was sponsored by the French Ministry of Health, and there's no further information about sponsoring in terms of what the authors received from the French Ministry of Health. In contrast, the other study that was sponsored by Abbott, numerous authors gave disclosures about receiving grants and talks and advisory board fees, and I would never mean to imply that this might have some influence on the results of these trials. It's all shown in the New England Journal, and you can judge for yourself. The next topic in the New England Journal is prostate cancer. And this is very common in elderly men who almost all get it. And the question is, what should be done about it? And it's detected by prostate-specific antigen, and then the men are subjected to biopsies, multiple punctures of the prostate gland, and these are evaluated according to a pathological score that was developed by a pathologist named Gleason. And he looked at the structures that he expected to see in normal prostate, small uniform glands, whereas in prostate cancer, all of these things become less distinct and less differentiated. And so the multiple biopsies are expressed in terms of a Gleason score. And you'll recall that this Scandinavian study, where these men were randomized to watchful waiting compared to radical prostatectomy, we now have 29 years of follow-up of these men to see if the radical prostatectomy results in better outcomes. And you can look at all the patients and the patients that were less than 65 years of age compared to more than 65 years of age at the time of randomization. Most of these men have now died because almost 30 years have passed since this study was initiated. You could look at their PSA values and surgery, yes or no, and what they got, and etc. Now, these plots are a little difficult to follow, but we look at 23 years of follow-up, and perhaps the most important is this one on top. And we see that the people that died of prostate cancer are here in the dark, and more people died of prostate cancer in the watchful waiting group than in the radical prostatectomy group. And people that received androgen treatment and had nevertheless had progression of their disease is also higher in this in the watchful waiting group. And if we look at the people that died of something else, this is perhaps a little less in the watchful waiting group than in the radical prostatectomy group. I placed these red lines here so that you can see these differences. And if we look at these graphs for people that are less than 65 years of age at the time of randomization compared to patients that were more than 65 years of age, we see a similar pattern. And if we look at death from prostate cancer or death from any cause or death with distant metastases, these are all less in the radical prostatectomy group. And if we look at the progression of metastases, etc., again, we see similar patterns as we did for survival, and they're somewhat less in the radical prostatectomy group compared to the watchful waiting group. And this result is despite crossovers and men changing their minds and being lost to follow-up and all of the various things that happen in a clinical trial that's conducted over 29 years of follow-up. And if we look at Gleason scores, I think it's important to look down here. Basically, what we see is that people that have a Gleason score greater than 7 or greater, they have an odds ratio of about 5.7, and those that have Gleason scores of less than that don't seem to have benefited if they got radical prostatectomy or not. So the higher the Gleason score, maybe you'd be more prone to advise your patient to go ahead and have the operation and be impotent and unhappy for 29 years, which can also occur. So if we look at that critically, what we find is that the patients that were in the radical prostatectomy group had a mean gain of almost 3 years of life after 23 years of follow-up. Important study. The next study has to do with acute myelogenous leukemia, which is a malignant disease of mostly older adults, as you can see here in this distribution of ages that's shown here. And all these awful myeloid precursors that are seen on this peripheral smear, there are no our bodies here. So there are various forms of this. They're all bad. And they're treated with fairly aggressive chemotherapy. And in failures, the patients receive allogenic bone marrow transplantation and more aggressive chemotherapy. And the question in this study is, it's known that this malignant disease progresses in spite of treatments. And how does this happen? Because the clones are almost obliterated from the bone marrow with the aggressive chemotherapy, but then the disease recurs, and the question is, are these recurrences based on genetic changes that happens in these cells? And since the transplants should come from someone else, should be aggressive against the malignant cells, are the genetic patterns that result in recurrences after transplant different than the genetic patterns that occur after aggressive chemotherapy? And this can be studied now by getting samples and whole genome sequencing or exome sequencing or complex FACS analyses or proteomics. A variety of techniques can be applied here. And that was done in this study. So what we see here are recurrences after allogeneic bone marrow transplant compared to recurrences after aggressive chemotherapy. Now, these patients were not randomized, and as I mentioned at outset, myelogenous leukemia is a heterogeneous disease, and there's small numbers of patients here. But what we see is that the recurrences in the transplant patients commonly involve genes or gene loci that we associate with immune responses, HLA, CD86, CD74. These things generally go down in the recurrences of the transplant patients compared to the recurrences of the chemotherapy patients. And if we look at FACS analyses at presentation compared to relapse, we also see different patterns. And the patterns are different in the recurrences after bone marrow transplant compared to the recurrences after aggressive chemotherapy. And these patterns are shown here. And again, the inference is that there is downregulation of immune-associated genes, raising the notion that perhaps the reason that the transplants aren't aggressive against the recurrent tumor cells is because their expression of immune markers has somehow changed, which would perhaps explain how this recurrence develops in these bone marrow transplanted patients that ought to have, since they have foreign bone marrow, ought to be more aggressive against recurrent tumors. And there are some examples shown here. I'm not an expert in this, as you can tell from my presentation, but here's a patient, clinical presentation, aggressive chemotherapy, all the clones are gone, then there's recurrence, then there's bone marrow transplant, and then with recurrence again, there's a different pattern shown here compared to the recurrence that was seen after the chemotherapy. And so the suggestion here is graft-versus-leukemia effect has perhaps an effect on the genetic changes that occur with recurrence. There is downregulation of MHC class II by interferon gamma, suggesting that this event is epigenetic in nature because germline changes haven't occurred, obviously. And somatic mutations would be detected by other techniques. So in conclusion, the AML cells that escape the immune surveillance provided by allogenic T cells after allogeneic hematopoietic stem cell transplantation had dysregulation of pathways that regulate immune function. Here is a small vignette. The picture on the left shows a 73-year-old man, and in English we call this the red man syndrome. This is kind of a cutaneous phenomenon that we see in patients that have a reaction side effect to vancomycin. They look just like this. But this patient didn't have that. He was a red man. Nobody knew why, and his rash didn't get better. Now, these kinds of rashes can occur with malignancies. And what we see in this CT is he's got a lesion here, which was excised. It's a non-small cell lung cancer. And with excision of this lesion, the rash goes away. So this phenomenon is known. This is a paraneoplastic erythroderma, and it responds to excision. Next topic in the New England Journal, checkpoint inhibitors. What else? And we know that there's interaction between MHC1 receptors and T cell receptors, and this is modulated with the interaction of PD ligand 1 and programmed death ligand that's on these activated T cells. And if we block this interaction of PD ligand with PD-1, we would expect that the T cells would be more aggressive against the tumors, and this has been shown. An antibody that we've already discussed at these exercises that blocks this interaction is durvalumab, which has been applied for patients with non-small cell lung cancer. We've seen this paper before, but here it is again, because now with prolonged follow-up of 43 months, we see that absolute survival is better in the checkpoint group than in the placebo group. As a clinician, I don't really think that this difference is enough to cheer from the rooftops, but it's statistically significant, and that's why we see this paper again. And this was the case, intention to treat randomization, and also for patients that actually got the treatment. So it looks like durvalumab in patients with non-small cell lung cancer improves absolute survival. The review in the New England Journal is substance abuse in old people. And one of the things that we've learned is that old people aren't that different than young people. But they're a little less prone to street drugs and more prone to alcoholism. Sorry, but that's the case. And that's what the review is about. And how do we define alcoholism? Well, you can define it as more than 5 drinks on one occasion in the last 30 days or something. Alcoholics are people that drink more than their doctors. And it's common. And it occurs in old people, and they show up differently than young people. They could have psychiatric problems, and they could have nausea and vomiting and tremors and this sort of thing. But more commonly, they have cognitive changes, such as confusion and disorientation, and don't know where they are, and don't react appropriately on social activities, problems of this nature. Now, alcohol withdrawal is treated in old persons similar as is treated in young persons, mostly with chlordiazepoxide, which has been around for years and is inexpensive. These are diazepines, and probably the simpler ones are better to use. And benzodiazepines should probably not be given routinely to old people for any reason, but for alcohol withdrawal, they seem to play a role. Naltrexone is also used. These other things are fairly toxic, and I don't think I would give them. So comprehensive treatment plans for old people with alcohol abuse is discussed here. Here's an eponym that you can memorize to keep these things in your mind. Old people also misuse prescription medications, and to be an old person and ingest less than 9 tablets, different tablets, is difficult. Use of illicit substances is also common, and recommendations are a little different than for younger persons. No controlled trials about this, probably should conduct some. The patient in the New England Journal is this 54-year-old man that shows up with heart failure. And we look at these tabular data, which are not very helpful. He's a smoker, is overweight, he's hypertensive, that wasn't treated very accurately, or he didn't take his medications, not so certain, but he comes in with 10-kilogram weight gain, short of breath, orthopnea, has a tachycardia, breathes 28 times per minute. His oxygen saturation is 96%, while receiving 2 liters of oxygen by nasal cannula. If you're an experienced clinician, you would guess that on room air, he probably has an oxygen saturation that's more like 85%, and a PO2 that's probably around 60. So he's got bilateral crackles in his lungs and substantial peripheral edema. Here's a chest x-ray on this poor person. Looks like he has a large, may have a pericardial effusion, but he has a pleural effusion on the left, a boot-shaped heart, markedly elevated left mainstem bronchus, suggesting that his left atrium is enlarged. Looks like heart failure. And if we look at this electrocardiogram, his cardiac axis is plus 90. That's okay. He has sinus rhythm. This is poor R wave progression across the precordium. There are no pathological Q waves here. And the ST segment and T wave changes are relatively nonspecific. So we're not certain what he has. He is examined, and his jugular pulse waves are elevated to 12 centimeters of water, which implies that his filling pressures are increased. Somebody looked at his fingernails. And he's got Quincke's pulses, and his carotid upstroke was examined, and it looks like he has a water hammer pulse, which was described by a clinician named Corrigan. Somebody listens to his heart, and he has a diastolic decrescendo murmur that's a little bit to the right of the sternum. I'm told that he has no third heart sound, which I can hardly believe. These other signs that are classic for this condition, that are all named after clinicians from the 19th century, actually weren't elicited. But one of the things that I think should have been done is somebody should have measured his blood pressure in his legs, because patients with aortic insufficiency have a marked increase in systolic pressure in the lower extremities compared to the upper extremities. If you do this on yourselves, you young people, you'll find that the systolic pressure in your legs is about 10 millimeters of mercury higher than the arms, for reasons that we can talk about later. And in patients with aortic insufficiency, this difference becomes markedly expanded. Pulse pressure also increases. And there are physical signs that I've outlined here that you can look at these things on your own. We now have echocardiography, so perhaps all this clinical information is now irrelevant, but it's nevertheless still fun. And here's his echo, and he looks like he has dilatation of the left atrium and left ventricle, and he's got aortic insufficiency, which is substantial. And if we look at these other imaging techniques, we see that he has marked dilatation of his ascending aorta, which results in a functional aortic insufficiency. And it looks like this is an aortic aneurysm of the ascending aorta, and this is not due to syphilis. So, what happens? He's got an ascending aortic aneurysm. He's operated upon, and what we see here are changes in his aortic media. We used to call this cystic medial necrosis. There are various causes that we can inspect. Some of these are genetic. We wouldn't expect them to show up this late in life. Marfan syndrome, Ehlers-Danlos syndrome, Loeys-Dietz syndrome, various genetic mutations, germline mutations that are associated with ascending aortas of aneurysms, syphilis. My cadaver, when I was in medical school, had died of a ruptured syphilitic aortic aneurysm. Tuberculosis possible, giant cell arteritis, Takayasu's arteritis, but the clinics of this patient doesn't suggest these items, although hypertension can cause this. And 70 to 85% of patients with thoracic aortic aneurysms have concurrent hypertension that generally is poorly treated. Postoperatively, this patient had a bunch of problems that you can read about in this report, but he eventually did okay. Now we move to the Lancet, and the first topic is what happens to international migrants and how is their health care? And migrants have been around for a long time. For instance, in the 1930s, between 1933 to 1941, 530,000 Jewish people left Germany. And in the vast majority of cases, the countries that they went to didn't want them. But nevertheless, migrant patterns have been around for years, and the question that is asked here, how's the health care of these migrants? And you might imagine if the migrants go from a country that is better off than the one that they left, their health care would improve. And this is a meta-analysis. And we can even hear people that migrated from the former Soviet Union to Germany are listed here, and people that migrated from Bangladesh to the UK And every country deals, there are people that migrated from Japan to South America. All of these things are listed here. And as you can imagine, if the people went from poor countries to richer countries, their healthcare improved. And why would you go from a poor country to another poor country? Well, this is occurring in where people are fleeing from Venezuela to Brazil. Probably their healthcare doesn't get much better, but they may be in less danger of being killed. So all of this is tabulated in these forest plots that you can look at. But basically, migration from poorer areas to areas with better opportunity results in better health care for the migrants. Guess we could have imagined that. What about the children that are left behind? Well, I guess we might imagine that they do poorly compared to children whose parents are still available. So we can look at a big analysis of these happenings. And indeed, these poor children that are left behind have worse health care outcomes. Very good. We're catching on. The next study in the Lancet is a randomized control trial of icosapentaenoic acid and aspirin alone compared to placebo to impair the further development of colorectal polyps, adenomas. And there's lots of reasons from earlier studies to believe that both of these strategies might be helpful. And that was performed in this large study where the primary endpoint was the adenoma detection rate and people at risk for developing adenomas 1 year later. And unfortunately for us, the data, first of all, we can see that the medication got there because we can look at icosanoid products in collections of free fatty acids and triglycerides, and these things go up in the treatment groups, and we can see that the patients took their materials that they were supposed to be ingesting, and also pretty good evidence that they also took their aspirin. Now the data are tabular in nature, but basically the primary endpoint was negative, although the trial suggested that both icosanoids and aspirin show some chemoprevention efficacy for colorectal cancer. I hope that's true. This next study is also amazing. Premature infants that are in intensive care units are subjected to a lot of procedures that are painful. Now you can't ask them if it hurts, and whether or not they cry out there's a lot of debate about this, ethical debate. Can you even experiment on these children? And if you provide analgesia for them, they have to get stuck twice instead of once, and this is a big problem. So what was done here, these premature infants in intensive care units were randomized to morphine or placebo, and judgments were made about whether or not the analgesia might expose them to some sort of risk, like stopping breathing, or if there was any evidence that they would benefit from this analgesia. This is a courageous study. And what we can see here is that, just some examples here, that EEG changes. I'm surprised that all these things can be monitored. Changes in heart rate, changes in oxygen saturation, apneic intervals, and things of this nature. These things were monitored, and what we can see here is that these things occurred, and a lot of them are more common in patients that receive morphine compared to placebo. For instance, standardized differences in desaturation at 6 hours, markedly elevated in the morphine group. Same kind of data shown here. Heart rate, don't know if I want that. And respiratory rate, don't know if I want that. And oxygen saturation. And these data suggest that these premature infants do not benefit from this strategy to provide analgesia. As well-intentioned as it might be, it seems to cause more negative side effects that are not desirable at any age. Now, the review in the Lancet, again, is about migration. And 1 billion people on the planet have moved in 2018. And since there's 7.5 billion people on the planet, this is more than 10% of the total are on the move for one reason or another. And this is a major phenomenon that's been around for thousands of years, but is particularly prominent now. And this entire complicated subject is discussed in this review. Short-term interception, long-term transient, permanent resettlement, remigration, return from where they came. And I think these data are telling. This here is, why are these people leaving? And the numbers of people that are leaving because of military conflicts or because they want asylum are trivial compared to the people that are moving for other reasons. And if we look at the people that are moving because of natural disasters, tsunamis, earthquakes, drought, hurricanes, markedly is greater than the people that are leaving for the things that we read about in the press every day involving armed conflict. And that's important. And where are they coming from? Africa and the Americans and Asia, and all of this is outlined in this review. And the myriads of organizations that we have that putatively are there to help these patients, they weren't around in the 30s. And how effective these organizations are is also discussed in this review and the things that need to be done. We're almost finished. There was a review in the Ärzteblatt that I thought was important because it involves the diagnosis of infections by blood samples. And we're aware of taking blood cultures. And if you have a blood culture that's positive within 4 hours, I think as a clinician, you'd be delighted, because then a gram stain can be done and you can at least classify the organisms in terms of that. But most organisms are fastidious and will require much greater time to grow. Now, there are things that can be done in the meantime, and Pcr Technologies, or nucleic acid amplification tests, as they're called here. And you can use specific primers if you have a pretty good idea, you know what you're looking for. And you can use generic primers that are less specific in attempts to make a diagnosis at the earliest standpoint, place and time as possible. And there are advantages. If you're interested in this, you can also acquire this paper in English language from the journal, or I can supply it with you. Now, what can also be done, as soon as you have some culture results, you have to have the organisms to be able to do this, is you can blow the stuff up with a laser and capture this in terms of time of flight, how fast these particles move across a given space, and then analyze them with mass spectrometry. And with this technique, diagnoses can be made. If you have a culture results at 4 hours, you can get information on ribosomal proteins to classify the organisms and make the diagnosis more quickly. And how these things can be combined in strategies to make a diagnosis of bacterial-borne infections as quickly as possible. And this can also be used not only to identify the organism, but also to determine what the resistance might be. And we've seen examples of this with multi-drug resistant tuberculosis and things of this nature. I think this is an important review, and we should know something about these kinds of things because they're going to be much more prominent in the coming years. And the next paper I wanted to show you is because Dr. Goodla asked about this last week, is exercise good for you? And here's a paper to that effect in the Journal of Applied Physiology, where young exercisers, it's you people, are compared to lifelong old exercisers, fanatics that exercise every day, and the ones that go to yoga class 3 times a week are compared to old people that claim that they're healthy, but don't exercise. And if we look at these people, age, height, weight, exercisers about 15 kilograms lighter, body mass index differences here, we would expect that. What interested me is that These patients, of course, are not randomized to these groups, but the amount of tablets that are swallowed by the really performance old exercisers compared to the people that go to yoga class compared to the couch potatoes is dramatically different for beta blockers, blood pressure drugs, thyroid, cholesterol, all that stuff. And if we look at how these are the women. Now, young women exercisers are pretty fit, but they're 20 years old. Good. Now, old women exercisers, the old ladies that are older than 70, are certainly better than the mean, and they're much better than the old couch potatoes. And that's true for the men also. And the more they exercise, the better they are. Now, muscle biopsies were done and biochemical studies were done in these subjects. I'm not going to bore you with all of this, but the vascular distribution, the blood flow, the blood supply in terms of vascular networks in the old exercisers was like in the young exercisers compared to the old couch potatoes. And we know that bad skeletal muscle function and frailty is what's associated with the negative outcomes in old people and decreased survival. Here's the patients with parvovirus 19 infection from last week. I learned to my surprise that this patient was from Dresden. And this is the lung transplant patient and these inclusion bodies are typical for parvovirus. And with modulation of immunosuppression, this patient did better. Thank you for your attention. That's it for English this week. If you'd like to hear the same spiel in German in 9 minutes, stay tuned.